Hi, Dr. Pelto here. I'm going to talk a little bit today about some patient transformations when dealing with plantar fasciitis and Achilles tendonitis. These are the most common conditions that we see that are involved into the heel. And I'm going to tell about the typical patient journey that patients come in with into the office. Now, thankfully, most of our patients don't have both plantar fasciitis and Achilles tendonitis. They have separate conditions. Occasionally coming with it on both sides, but frequently they do not. So let's talk about both Achilles tendonitis and plantar fasciitis. They're both treated virtually identical. And the reason they're treated identical is because they are caused by the same types of problems. And one of the biggest problems is tightness in the back of the calf. Now, it's important for us to talk about these conditions because these can be debilitating. Both Achilles tendonitis and plantar fasciitis cause pain when our patients get out of bed in the morning. It tends to get a little bit better as they're more active, but as they're doing stairs and towards the end of the day, they tend to have more pain. And for the most part, it's something that doesn't go away, just giving it more time. I'm going to first go over what patients try to do before they come and see us. Most patients, they try to get new shoes. They'll try some icing. They'll try some anti-inflammatories like Motrin or ibuprofen. They may try some stretching exercises. They might try some CBD oil or cream. They're going to try a lot of these different things, and they're probably going to spend about $200 or $300 online with things that don't work. Once they get frustrated and they think it's never going to go away, then they usually seek out a specialist. There are certain people that go to a primary care or they go to an urgent care. But unfortunately, usually at urgent cares, emergency rooms, or primary cares, you're not going to get treatment. You might get an x-ray, you might get an anti-inflammatory, but they're going to refer you to a specialist. So if you want to save time, I would go directly to see a specialist. Now, the first part of the patient journey when they come and see us, we usually get x-rays, and then we'll look at the patient walk, and we're going to see if there's any pronation or flattening of the feet, and we're going to test their feet, specifically where the pain is. Achilles tendon pain is on the back of the heel, and plantar fascial pain is on the bottom of the heel. Both of them hurt when you push there. Now, occasionally, the one on the back of the heel is going to have a big bump. It's called a heel spur or a Haglund's deformity on the back of the heel. That is where the Achilles tendon, it inserts into the heel, and that can be one of the more challenging types conditions to treat in the heel. After we watch them walk and after we do the evaluation, I usually start with the first line of treatment. So let me explain the first line of treatment. So if you want to save some time before you go see the doctor, you can try these things. The first line of treatment is usually a couple weeks of a strong anti-inflammatory. I like meloxicam, 15 milligrams if you can take it. I either have patients do icing for 10 minutes twice a day or something called a contrast bath. A contrast bath is a bucket of water where you put your whole foot in there for 5 minutes in the ice water, 5 minutes in the hot water, and then back to 5 minutes in the ice water. And I try a couple of those things, and then patients, they try that for a couple weeks, and then they come back in. And at the follow-up visit is where I'm going to most likely do an ultrasound. So that's to get down the pain. To get down the tightness, I usually have patients start with a combination. I call it the Pelto special. They're going to be getting a night splint, which is something that goes in the back of the heel, both for plantar fasciitis and Achilles tendonitis because of the tightness. Most likely, they're going to get a towel stretch. They're going to take a towel or a belt and stretch before they get out of bed. And then also, they are going to get a foam roller. We're going to roll out the back of the calf, and that's to loosen up the tightness in the back of the calf. And then the third component is to help stabilize the foot. And most of my patients, I'm recommending UFO sandals, which are a good sandal with a high arch support. I'm going to recommend new shoes because most patients these days are coming in like with Nike or Adidas or maybe Skechers, those types of shoes, which I don't think they're the best. I recommend, even if you're not a runner, to start out with a running shoe. And my best recommendation is go to a running store. Even though you might be tempted to buy things online, I like going to an established local running store because they can help you out and they'll take the shoe back if it doesn't work. A couple of the good brands are Hoka, New Balance, Asics, Saucony, things like that. There are others, Brooks. Now, if you have a very wide foot, I like Ultra and Topo as a type of shoe. I would start with more of a supportive shoe, and then you may want to try an over-the-counter insert. One of my favorite ones that you can get on Amazon is called a Walk Hero insert. My patients are going to try that combination for about 2 weeks, and then I usually see them back in the third week. Why do I do it the third week? Well, I want them to be on the anti-inflammatories for 2 weeks, and then I want them to be off the anti-inflammatories for another week so I can see the effects, to see if there was some lasting effects. Then at the second visit, when I see the patients in the office, I'm going to evaluate. If the pain continues to be there, then we're going to go to the next step, which usually involves an ultrasound. The difference between an x-ray, which I get on the first visit, and an ultrasound on the second visit is that I can look at the soft tissue around the area, specifically on the bottom or the back of the heel, where I can see if there's areas of black, which is considered an effusion or swelling on the back of the heel or the bottom of the heel with that ultrasound. Then when we look at the tissue, I go to phase 2. If there is thickness in the tissue, if there's swelling around the tissue, then normally I'm recommending a series of shockwave treatment. Shockwave is also called EPAT, and I think this is the best way to help your body heal itself. The reason for that is that on the bottom and the back of the heel, you have a kind of a ligamentous type of structure that's white called the fascia or the Achilles tendon coming down in the back. Both of those don't have the best blood supply. And what happens when you have constant injury, because you're constantly walking, the tissues get thicker, and we can see that on the ultrasound. If they are thicker, that makes it harder for them to heal, and that makes them less flexible. So what we do is we do shockwave, which impacts it, which helps them kind of like a meat tenderizer to reduce a little bit of the tightness. It doesn't really take down the thickness, but it helps them to improve blood flow to the area. It's called regenerative medicine. It's your body healing itself. So I give a specific dose to that area. There's usually 3 treatments, and then they're a week apart, 3 to 4 treatments. If you've had pain for over 6 months, you might need up to 6 treatments. So I do the shockwave. Occasionally, if there's an area of a little tear in the Achilles or the plantar fascia, that's where I'm going to add something else called an amniotic stem cell injection. That's an injection that I put in either in the back of the Achilles or the bottom of the heel, and that helps promote healing. That's going to be at a future visit. Then what I do for the next step is that once you finish the shockwave, you're going to schedule physical therapy. And I find that patients get better faster with physical therapy. So you're going to go to physical therapy after you finish the last shockwave treatment. And then after the physical therapy, you're going to come back to the office, which is usually at 6 weeks. In terms of your shoes, if you have a lot of flattening of your foot and the shoes weren't sufficient, I may recommend an orthotic. Now, I find that orthotics are helpful a little bit to get down the pain, but they're much more effective at correcting the mechanical instability in your foot and helping the problems not come back. And therefore, an orthotic may be done down the road. I'm going to make sure you got good shoes. I'm going to make sure everything else is working with type of shoe gear you're wearing. Now, if you're having a lot of pain, occasionally we'll put patients into a walking boot. Now, with this typical protocol, I get 99% of patients better that have plantar fasciitis and Achilles tendonitis. There's a certain subportion that still needs a surgery, and that would be either with cutting through the plantar fascia or detaching and reattaching the Achilles tendon. This is a rarity with these new treatments that we have nowadays. It is very possible to treat plantar fasciitis and Achilles tendonitis. You don't have to suffer. I've put all of my videos and all my patient protocols in something called a foot treatment toolkit. So I'm going to put a little link under this video so that you can get access to this foot treatment toolkit to learn how to treat your condition. If you're seeing another doctor or if you're thinking about seeing a doctor, I would recommend doing that before you see them. Go see them in the office.